Ooh, give her a big hand clap.
Hi, everybody. A few people I know. I actually don't think I need this, but so I see a few familiar faces. I'll get the first question of the night out the way. Most people want to know where I'm from, and I'm from Mesquite. Okay? So I'd like to welcome Dr. Cindy Marshall tonight. Dr. Marshall is the expert in Dallas. Her and I have worked together off and on for probably 20 years. She's my go-to person for families who need assistance and help. She runs the Baylor Memory Care Center, I'm going to call it clinic, with a whole team of experts. So anyone here tonight who has a loved one or is worried about their own memory, you need to get it checked out because it's not always Alzheimer's. I know we're all afraid of that. My job here is I am Director of Dementia Programs for Christian Care, which means I work in all the communities, Fort Worth, Allen, here, and anyone who needs assistance regarding memory, or teammates, or residents, families, anyone from the outside, they can call me and ask me. And I won't tell them what to do, I'll give them information. And so if you ever need anything, my cards are at the back there. But main thing, Dr. Marshall, and I hope you all enjoy her program tonight.
Sorry, I've got to get set up. I'm kind of sad, Mary, you told how long we've known each other because I think that tells us how old we are too. But yes, I am here for Mary. I have worked with her since I've been in Dallas, which is exactly 20 years. So it's a joy to be here. Thank you for having me. This is my first live lecture in the pandemic. So I'm had to dust off the jacket and do some stuff. But we will have questions at the end. So this is a pretty technical talk. Over time, I realized that my audiences have gotten so sophisticated. So don't worry if it's above or below. We're just going to keep on trucking. I did leave time at the end to talk about the new drugs, because that's probably half of what I talk about at every visit that I have. What drug we have, what drugs are coming, how do we pick, etc. Okay, I don't think any of my disclosures would affect today's talk. So you're going to see this slide multiple times because I'm going to discuss off-label, meaning not approved by the FDA. I think I have 2 slides that are FDA approved in the whole talk, and that's why I don't give out handouts, is because pretty much everything I do is not sanctioned, meaning that there's no one who's gone for FDA approval for any of these things. So you'll see this a lot, that everything I'm teaching you is stuff that we do but don't have FDA approval for. Okay, so let's talk about chemistry. When we talk about Alzheimer's, we always talk about plaques and tangles and that structure, but what I do is a lot of cooking. And so we look at the chemicals of the brain, the neurotransmitters that already live there, and we see if we can alter them. Okay, so 3 changes happen in Alzheimer's disease. We have a decrease in acetylcholine, which is simply put our memory chemical. We have glutamate, which is a good chemical in the brain, but it becomes excited and it literally pounds at the neuron and kills it. But you can't block all glutamate because we need it for other good things. And then we see a decrease in serotonin, which leads to the mood changes and irritability that we see in Alzheimer's disease. Again, you'll see it again. So when we decide as doctors what we're going to give someone, it's not so much like what drug do I want, it's like what do I want to do in the brain? Do I want to increase a neurotransmitter? Do I want to decrease a neurotransmitter? Like what do I need to do to make the situation better? Then once we know what we need to do, we can narrow down our drug choices by risk, benefits, and side effects. So back to serotonin. So if our serotonin is low, well, let me put it a different way. If we raise serotonin, we have less depression, less anxiety, less irritability, and less agitation. So that's pretty good. If we increase norepinephrine, we get more get up and go motivation and stimulation, which sounds great, but when dementia, sometimes we have to think about that some of our folks are already a little too agitated or stimulated, and we may not want them to have norepinephrine because it may make it worse. Do we need to block dopamine? So dopamine's a movement chemical, but also in excess, we can get delusions and hallucinations. So when we have psychosis and agitation, sometimes we block dopamine. And then sometimes, honestly, we have to do a little sedation. That's never our first choice, but sometimes we have to. So we have the light way to do that, which is trazodone. That's an old school antidepressant. Most of us know it as a sleep pill because if you take enough to be not depressed, you're too sleepy to enjoy it. So we can't really use it for an antidepressant very well. And then benzodiazepines, which is what we call Xanax and Ativan and clonazepam and Klonopin. So we're going to start off with one thing that's FDA approved. Like, what do we do for the cognitive symptoms of Alzheimer's disease? So here are our drugs. There's two categories: the acetylcholinesterase inhibitors, which is just a fancy word for allowing our brain to use more acetylcholine, our memory chemical, is donepezil, rivastigmine, which also comes in a patch known as Exelon, and galantamine. So those are indicated for mild disease, and donepezil is indicated for moderate. Memantine is our drug that works on glutamate, the chemical that, when overly excited, can pound at the cell and cause neurons to die, but yet we still need it to do some good things. Memantine or memantine long-acting are the two drugs we have for that. And then because we have not had any new drugs till last summer, Namzaric is a combination, which it puts donepezil, full-dose donepezil and memantine in the same capsule. So I get asked this all the time: do these medicines work? So there are three things these medicines do. So promotes activities of daily living, so maintaining our independence. It reduces behavior problems, and it helps tread water with cognition. That doesn't mean better. I do have folks who get better on these medicine, but I don't want to say we can make memory better, not consistently. It's more just to hang in there and tread water while we wait for better things. And for once, we're probably in the era of better things. I've been doing this for 20 years. If you had told me it would take 20 years to get to where we are today, I would have never believed you, okay? And hopefully more good things are coming. So a lot of folks get frustrated with these medicines because there is a point as Alzheimer's advances where the short-term memory kind of get up and leaves. And so the short-term memory is just not there anymore. And people get frustrated. You know, like, why should we keep taking it? Now that they're all generic, we have a generic, it's a little bit different conversation. But what I like about these drugs is that if you look to our European friends, they do a lot of socialized medicine and they have lots of databases. So love the Swedes because they have a database that showed that the folks who took just the memory medicine needed less behavior medicine and less sedatives. And that's what I see in my clinical practice, is that if we get people on medicine early, then we have better outcomes later, even though we're not making the memory better. So when people ask me, do they work? I say they do exactly what they're supposed to do. They don't do anything more, and they don't do anything less. So now we're going to talk about the psychiatric symptoms that we see. We're going to break it down in categories. So we're going to talk about depression and anxiety, then irritability, because they're not the same, and then paranoia. So depression and anxiety. So again, back to those neurotransmitters, we have two to work with, serotonin and norepinephrine, and we can have combination. And I'd meant to include a slide, and I apologize because it didn't show up in the slide deck, but the serotonin drugs that is like a Zoloft or a sertraline or escitalopram or Lexapro, those are those drugs. Norepinephrine drugs tend to be bupropion or Wellbutrin. There's like 4 formulations of that. And then we have combination drugs like duloxetine, Cymbalta, venlafaxine, Effexor. So this is where we can use them. So if we're looking for just antidepressant, we have lots of options. We can use serotonin drugs, we can use norepinephrine drugs, or we can use combo drugs. Anxiety does not do well with norepinephrine because that's our get up and go stimulating one. So if we're anxious, that's probably not the best choice. And the same for agitation. Probably don't want to get too much get up and go if we're already agitated. And then I get asked this, do they work? And the sad answer is we can't prove they do. But we'll talk about that. I included this one just more because I actually made this graph, and I'm very proud of it. So this is looking at 7 different studies of looking at antidepressants for folks who had Alzheimer's disease. And even though that green looks great because there's a better response than the placebo, the sugar pill, statistically it didn't separate out. So in medicine and all these research, and if we have any researchers, please correct me, but essentially sometimes what looks like a trend can't be attributed to anything more than chance. And so this is what they're saying. So there's another drug that did another study looking at mirtazapine, which is Remeron, sertraline, which is Zoloft, and placebo, which also showed that the folks on placebo did just as well. And then they took another look at it later, years later, and again found it didn't matter. So then, well, do we use them? I have no idea why it's coming in from the right there or left here. But we just don't expect drugs to do everything. Yes, we use them. So we do a lot about environment. So one of the things that those of you in this room who do know me will hear me say is that we can't use drugs to make an unmanageable environment manageable. So if we have somebody, let's say, who's in independent living and needs more care, and they wake up and they're confused in the morning and they're not sure where they are and they're frightened, there's not a drug I can give to make that go away. We can take the edge off of that, but at the end of the day, we need to look at what else can we do so that we aren't waking up in a room where we don't know where we are. So outside of that, because I don't believe that drugs do everything, I believe you have to come at things lots of different ways. So how else do we help the mood? Not being isolated, which has been a real problem during the pandemic, because whether you live in senior living and you're isolated or at your house and you're isolated, a lot of people were isolated. Okay, that doesn't help mood at all for any of us. So we need to increase the activity level. We need to get moving. We need to be exercising. We need to have some cognitive stimulation using our brain. And we need to have social stimulation to see people. So next, I'm hoping my video worked, that we look at irritability. So that's that little snippy, like instead of an answer, it has a tone to it or it sounds real snappy. That's one of the earlier signs that we see in Alzheimer's disease. And I'll see if my video will play. Ooh, that might be loud. So that's it. That's what we would call irritability. And the way that we treat that is the same serotonin drug. So SSRI just stands for serotonin reuptake inhibitor. So it's that same Zoloft, sertraline, escitalopram, Lexapro family. So then we get to paranoia. So when we have, in Alzheimer's disease, we can see psychosis. And I want to do some terminology. So hallucinations is seeing something that isn't there. And a delusion is a fixed false belief. So hallucinations are actually very uncommon in Alzheimer's disease. So a lot of times folks will say, well, you know, there was somebody in the house and they took my stuff. But it's not that they necessarily see the person in their house. It's just they know that their stuff is missing and therefore someone came in the house. Or they know that their mom is there, even if their mom's passed away. So we call that's in the delusional family. And the common examples we see are stealing. So again, I can't find it, you must have took it. In senior living, we see that a lot. A lot of staff get accused of pretty bad behavior for taking things out of the room. And then the spouse is cheating. So whether the spouse goes to the grocery store and then there's an accusation of, I know what you're doing, I know what you're up to. And what makes it so interesting about it being fixed and false is that it literally is fixed and false. So that's why when someone accuses a son of stealing the money when they're paying the online bills, you can show that bank account statement. You can show it on Bank of America. You can show that the account isn't changing, or maybe it changed to pay a bill. But that same person's going to be convinced. So it's fixed and it's false. And you can talk it out, explain it, and show bank statements for years, but it doesn't change the thought. And that's what makes it a delusion. So what do we do for that? Oh, I put the drugs up here because many of you in the room may recognize the generics are on the left and the brand names are on the right. So these are the commonly used drugs. They have incredible side effects. So sedation, dizziness, lowering blood pressure when you stand up, can make you eat more, gain weight, develop Parkinsonism, not Parkinson's disease, but kind of like the shuffly slow that you can see with Parkinson's. You can get that from blocking dopamine. and elevated cholesterol and blood sugar. And then if that's not enough, we have an FDA warning on the use in dementia. So the warning doesn't count unless I'm giving it to someone who has a diagnosis of dementia. And the warning is defined as a 1.6 times increased risk of death through stroke, heart attack, or infection, which is usually pneumonia. So whether we use it or not is based on kind of the risk and benefits. So back to my Bank of America story, if the worst that happens is that I have a patient who's accusing her son of stealing her money and she talks bad about him to her Sunday school class, that's not a big problem that I feel we have to medicate. If we're going to the bank every day and demanding to talk to the manager and calling the police on our son, that kind of like means we might need to do something different. So this is our definition of agitation. So agitation is a lot of things, and I put kind of the more common definitions here. It can be pacing or wandering or picking or restlessness or cursing or verbal aggression or yelling, hitting, kicking, biting, scratching, throwing objects, destroying property, shoving, slamming doors, or resisting. But my favorite technical definition is any behavior you don't want. So that's what we think about. Again, no drugs with FDA approval for the treatment of agitation. But agitation is more complicated than just simple depression or irritability. So this is what I do, okay? So the first thing that I give folks is serotonin drugs, the same thing we keep talking about, because if I can decrease the irritability, sometimes I can decrease the agitation. Let's say that ain't working. Then we use the low-dose trazodone. That's that old school antidepressant, and I can use it for just a tiny bit of sedation, but it doesn't have the heavy hitting effects of like a Xanax where it's gonna markedly increase fall risk and risk of altered mental status. So we add that. Mood stabilizers, which are used a lot, mine is crossed through for a reason, and we'll talk about why. Depakote is probably the most common one. There was like a period of time, and Mary probably remembers this time well, that everyone who went into the hospital came out on Depakote, every last one of them, because we felt that we were somehow stabilizing the mood like we would in a bipolar disorder, that it would help. And then the antipsychotics, which we just talked about, that have the FDA warning. And last is the sedatives, the benzodiazepines that we use. So how do I dose it? So if we're gonna get past just serotonin drugs and we have to add on, then we want less in the morning when you want people to be awake and alert. For all of us, at least my brain works best in the day and it kind of fades at night. And so we want to make sure that if we have to add on medicine, that we're getting it ahead of what we call sundowning. And sundowning was named for when the sun goes down, that people get more confused, but you can sundown in the middle of the day. So it's kind of a misnomer, but usually there's a time when we say, when do things go south in your house? And people will say 2 or 4 or 5. We want to make sure we're ahead of that when we dose extra medicine. It's just like pain. Like if you wait till pain is really bad, it's really hard to get a handle on it. So we need to be like right as it's going on the upswing and not trying to take someone who's agitated, confused, and give them a medicine at the top of the agitation peak. It just doesn't make sense, and people don't want to. We do want people to sleep through the night. We don't use sleeping pills, but we have studies that show that being up in the night makes you fall, not necessarily the medicines you take at night. And I also think that if my patients sleep, my caregivers sleep, which is good for everyone's mental health. So, is there any evidence for what I do? I think you're going to guess this, but any evidence for what I do to make agitation better? So, there are studies. Cochrane database is like a medical database where they just take on topics. So, they'll say, do statins work to lower cholesterol? And they'll look at like hundreds of studies and narrow it down by scientific vigor and pair them together. So, when they say something, we can listen to it. So, there are some benefit to doing the serotonin drugs, which is good. The mood stabilizers, that magic Depakote, not a lot of studies, but it's been looked at, but people they don't have positive results. So 5 out of the 6 studies showed no difference or worsening. So I don't use it. If someone comes to me on it and the family tells me that it's going well, I'm not gonna take it away, but I don't give it. And you have a lot of side effects, much bigger fall risk on the medicine. So back to our bugaboo of the antipsychotics, again, that FDA warning, and we only use them if we need them. So do antipsychotics work? So multiple researchers have tried to answer this question, and a lot of what they found out is that us doctors change medicine way too much. So it's very hard to measure. But that same Cochrane group looked at it, and this is what, I'm going to read it because it tells you in some ways like how hard it is for doctors to interpret this. So when using antipsychotics, they saw significant improvement in aggression with risperidone and olanzapine, a significant improvement in psychosis with risperidone, which sounds great, like let's all take risperidone. However, risperidone had a significantly higher incidence of adverse events. And then the medicine that a lot of folks are familiar with, quetiapine or Seroquel, wasn't really studied prior to this. So that's the one that we use the most. So it's just really hard to know what to do. So again, do they work? There is evidence they work, but you have to consider the risk. And so do I use them? Of course I use them. So environmental, I'm very big, again, not just drugs. Environmental interventions are often more helpful than the pharmacological or drug ones. So they're the things that we do a lot at Baylor, where I work, caregiver education and support. So we want our caregivers to understand the illness and understand what they're seeing and to be able to react and keep their mental health intact. So part of what we do is teach about why we don't argue or correct. So if someone's saying, hey, you know, where's mom? Mom passed away. We don't get out the obituary and we don't try to explain it. You know, we come up with something. Now, sometimes people are big on honesty, and usually I am, but I found like some wiggle room in the middle, and I give myself grace for that. So if someone's going to ask me where mom is, I might say, oh, I haven't seen her, because I haven't seen her. But I don't see the need of keep talking about something. Or someone tells me, a lot of my gentlemen are like, yeah, I'm still working. And they're not working, but that's fine for them to tell me they're working. It's totally fine. And so we just don't want to create, you know, confrontation and correction. We also want to protect our caregivers' hearts. What about when you're being accused of bad behavior? You're giving up everything to take care of your loved one, and they're accusing you of cheating or stealing. I mean, that's kind of crummy. So we want to protect our caregivers and help them with their hearts too. Structured environment is huge. So sometimes the environment is just too big. So it would be like us like trying to live in a big mansion. It's just too big. So the more we can shrink the environment and have a routine, the better we are. It's the same principle we do for our young people whose minds are developing. So when we send them off to school, there's structure. There's drop-off time, there's classroom time, there's snack time, there's nap time, there's lunch. And everyone does it together. So it feels very safe. We want to do the exact same thing. And we're not being patronizing, it's being respectful. You know, we're not treating people like children. We just want them to have success in an environment. There's nothing worse than trying to be 100% and failing at it in your current environment when you could maybe function better with less on your plate. And that's where the higher level of care. So independent living, assisted living. Assisted living is a little bit of a misnomer to me, because if you don't need help with your shower or bath, or just have your medicines given to you, it's not a lot of care. And then there's a lot of hybrids between assisted and memory, and then memory. And everyone likes to have sweet names for the programs because it's so hard for a family to tour and to look at memory. You know, they want their loved one in independent living or assisted. And it's just tough. But if we hit the level of care right, we do a good job, and you can have that care in your house too. So here are some resources. The Dallas, they're now called the Dallas and Northeast Texas chapter of the Alzheimer's Association. They never went back to the office in the pandemic, but they are going to be going back to a new office. So they were kind of in the Knox-Henderson area, and now they're going to be up near the Galleria, but I don't have a date for when that's going to happen. But everything for them is virtual until I think this week they're starting live caregiver things again, but everything is online. So you can take caregiver classes, education classes. Their website is great. They have a 24-hour helpline. So if you're at midnight trying to convince someone to go to bed and they want to go get in the car and drive, you can call the helpline. There's somebody there to help you. And they will do an individual care consultation. We are so blessed at Baylor that through grant funding, we have our own person in our office, which is super duper. And she'll do an individual care consultation. But Tanisha Tyler Carr does the same for the Dallas chapter. And she'll sit on the phone with you or on a video or hopefully soon in person and go through what's going on in your family and how to help. The day programs we have Friends Place, both in Richardson and DeSoto. We have Encore in Plano, and we have Golden Grace in McKinney. Everything, sadly, is pretty central to Dallas. The farther out you get from Dallas proper, the harder it is to find stuff. Memory care facilities, I was dropping a hint to Mary Poole earlier and her associates that we are waiting anxiously for these day programs to open up again so that folks in the community, so the Mesquite community, used to be able to come just for the day and enjoy the activities and have that structure and routine and then go home at night. So we're hoping that when the pandemic woes get a little bit better, that'll be an option. We also have church and synagogue-based programs. They tend to be either once a week or once a month. So Casa de Vida is at North Park Presbyterian. There's like Friday Friends at Wilshire Baptist, and just a lot of great things going on. So companion care, you can bring in help in the home to keep people busy. We don't want companions sitting there looking at their cell phone. We want people out and about doing things. Respite care is wonderful. That means you need to go out of town and you can know your loved one is safe and sound in memory care for a short period of time. I've had a lot of my families use it when someone had to have a surgery and they were not going to be able to physically be able to help. Maybe they were going out of town for a wedding. Maybe they're going out of town for a funeral, and it just wouldn't be appropriate to have their loved one come. And so you can do a respite stay in a memory care facility and just know that everything will be taken care of and you will have a little bit less on your plate when you travel. We have geriatric care managers here throughout Dallas. You do pay them, but it's great when you have family who's out of town, when you don't have kids here or spouse here, that they will go and take your loved one to the physician office and send out an email to all the kids about what was covered. The no cost is always the hardest. So Texas Department of Aging, Area Agency on Aging during COVID actually was providing vouchers in South Dallas for Friends Place DeSoto, but you have to do an application. It's a little bit more stuff you have to do to get. In Senior Source, I have not heard that they've restarted their companion program. So research, what's going on or maybe what's not going on. I know it's 2022, but I'm always struck by this statistic that between 2002, which is when I finished residency, and 2012, there were 413 Alzheimer's drug trials, none of which went anywhere. So what did we learn? Now, we did learn from that. It's complicated. We talk about plaques and tangles, but when we remove plaques, people don't get better cognitively, which will come up in a second. So why is that? And that's because once those plaques are there, they do damage throughout the cells, throughout the connections. So by the time we get to the plaque to remove them, there's probably so much damage to the cells that taking the plaque out is just not going to make a big difference. It's not going to recover the cell. So maybe we've got to get there earlier. And that's kind of, I think, the prevailing thought. There are people who will argue it's amyloid or tau. I think most mainstream people, like myself, would say it's both, and they drive each other. Amyloid has clearly come first. Tau drives the worsening. I mean, I think that's pretty well proven. So we're going to talk about what they've tried. And again, if you've been around as long as me, they've tried lipid lowering, insulin lowering, estrogen raising, steroids. None of that panned out. But if you take it down to the targets of the amyloid and the tau, they tried to prevent the formation of beta amyloid. So amyloid starts as a precursor protein, and these enzyme comes in and clips. And then somehow that clipping goes badly, and that's what creates that sticky amyloid that gathers together and makes the plaque. So they looked at, hey, can we take these enzymes and make them behave better? But the reason there's an X is, unfortunately, when we do that, there's so many things in the body that rely on these enzymes that we created other new and bad problems. So they have not been able to get around that yet. So now we're still looking at clearing it. So it's already there, but we're going to try to clear it out. And the predominant research over the past, I would say 10 years, has been on amyloid antibodies, particularly in early disease like mild cognitive impairment or mild Alzheimer's. And now some data shows about taking people who have no cognitive impairment, but when we put them in a PET scanner, they have a positive amyloid scan. So they have amyloid plaques, but they don't have memory impairment. And does that mean they don't have memory impairment yet? We don't know, but there are trials looking at giving these drugs to folks who just have amyloid but no memory problems. So tau is kind of later. The development of tau antibodies is much more recent than amyloid, so they're just not far enough for us to say a whole lot about them. One of the newer targets, and we have two research sites in Dallas, and we'll have a third probably by summer, is on filament A, and I have a slide on that. And then inflammation has just always been there, but we just can't capture a meaningful intervention there. So the simufilam is different because it doesn't remove amyloid. What it's trying to do is stabilize the membranes of the cell to not allow the amyloid to bind. So it's a little bit different. And the best part of this drug is that the studies allow moderate Alzheimer's disease. So in the past, only the wellest of the well could get into a study because drug companies didn't want to study anyone who wasn't mild because they want to show an effect. And so pretty much along the way, anyone with moderate or late mild, they just left. There was just nothing to offer them. But this one is going to allow to go down to moderate, which is super. But again, it's a study, so there's a placebo arm. You could get drug or placebo. And again, the big question is, if we can reverse some of this binding, does it translate to making the cognitive better? I was telling Mary I wish I could have like fireworks or something. So Aduhelm or aducanumab has created a whole lot of excitement for such a little vial, but it's created a lot of excitement. So it's our first FDA-approved drug in a very, very, very long time. So what is it? It's a monoclonal amyloid antibody. Essentially, it mimics, our body creates antibodies to what they call foreign invaders, whether it's a bacteria or a virus. It sees something it doesn't know and it attacks it. So what they're doing is trying to create a product that will do the same thing. And will it clear out those plaques and maybe prevent the plaques from forming? It's a monthly infusion, so once a month you sit with an IV. The biggest risk is, it's called ARIA, amyloid-related imaging artifacts. 35% of folks have them, and this translates to swelling and microbleeds in the brain. So these are little vessels that burst for most people. So most people did not have a clinically significant change having the swelling or the bleeding, but some did. And we don't have great predictors of who's who. However, in the studies, they did exclude folks who are on blood thinners, and that doesn't mean like aspirin. But if you're on Coumadin, you're not going to be able to receive the drug. And they have lots of rules about if you already have one little hemorrhage, how many little hemorrhages can you have, and lots of MRIs before the dose goes up. So their road to approval was very different, and that's why it was so in the paper all the time. So they did 2 large phase 3. Phase 3 means, does this drug work? 2 large trials. Drug companies regularly stop and look at data along the way because they don't want to keep going and frankly waste money and time if it's not going to benefit people or the pocketbook. That's just the way it is. So when they stopped to look at the data, one of the studies was clearly going to be negative, and one of the studies trended to be positive. But in FDA language, you can't go to the FDA with 1 out of 2. So that's, because it's a toss-up to them. And so they stopped it. It's called futility analysis. They said this is futile to keep going, so they stopped. So both studies stopped. Then Biogen looked at it post hoc, just meaning after the fact, and then found a subset of people who had the higher doses of drug that showed some benefit. So they filed for accelerated pathway with the FDA, meaning I can go faster because I'm going to be a groundbreaking new medicine. Their original price was $56,000 a year. So the FDA advisory panel, now this is not the FDA. These are the smart people, the scientists, who they bring in on new drugs and say, hey, look at all the data, give us an expert opinion. So there's 11 of them, 10 voted no, and 1 voted uncertain. So certainly that made a lot of folks think, well, it's not going to get approved. But the FDA did approve the drug in June of last year for the treatment of Alzheimer's. That was all it said, treatment of Alzheimer's. They later restricted that to mild cognitive impairment or mild Alzheimer's disease. So Medicare is taking its sweet time on how it's going to cover it, probably trying to make sure it doesn't overspend, and there was talk of raising premiums and all kinds of things to pay for that. And as CMS waited, that also caused Biogen to cut the price to half, I assume, to try to help the weight on their favor. The FDA has been widely criticized for this because the data was weak. They went against the scientific panel. And their rationale was it was reasonable that the amyloid clearance would translate to clinical improvement. But we have lots of trials that have cleared amyloid that did not lead to improvement. And then they were criticized for approving it for Alzheimer's disease, and they were going to let the doctors decide who get it, even though Biogen never looked at anything past mild Alzheimer's disease. And then overall, their behavior was just inconsistent with past decisions. Okay, but it's here, so it's available, so who can get it? So if you have Medicare, which I assume most people do, Medicare is still waiting on the final ruling, but their preliminary ruling was you can only get it, or they'll only pay for it if you're part of a study. And part of the agreement for the FDA approval is Biogen is conducting a large study looking at safety and efficacy so that everyone in this trial gets drug. There's no placebo. So everyone who wants to have Aduhelm, Medicare will pay for it, at least unless they change their mind in the next few weeks or waiting for their last decision, can get the drug. But you do have to participate in the safety and efficacy trial to do it. The commercial insurances typically follow Medicare. They don't have to, but they typically do. And then you have the cash pay option. So that is the $28,000 a year. I have not been able to get clarity on whether Medicare is going to cover the infusion. So just the drug is one cost, but the nurse who puts the IV in your arm and the infusion center, all of those are extra cost. We have some folks who've told us that Medicare is paying for that piece. And then Biogen is willing, of course, to work with folks who cannot afford it or to kind of front the medicine, if you would, with the idea that Medicare might eventually pay. So who's coming up next? Well, obviously, seeing the aducanumab get approved, a lot of drugs that were going to wait a while to apply are now applying because the market is good for them. So Lilly is coming behind with donanemab, which they say, of course, is bigger and better than aducanumab. Biogen and Eisai have lecanemab, also reporting they're bigger and better. And then Roche and Genentech is doing gantenerumab, which is actually a injection in your stomach. We probably won't know. I would be surprised if we know at the end of this year. Lilly in particular was probably the first of these drugs to apply. They're saying that they expect a decision early next year. So we will have the aducanumab now, and then we have these three drugs possibly being approved, or one or two being approved maybe by this time next year. So then the next question is, what do we do? So how do we decide? So for folks who are in mild cognitive impairment, they probably have a year that they're not going to go down, or they're not going to go down much, and maybe they go to mild Alzheimer's disease, but they'll still have choices. And so they can literally choose. So some folks choose, well, hey, I want to do something. Some people say, hey, I'd like to wait and see what it all looks like when we have more information. And that's reasonable. I also have some folks who realistically would barely get in now and certainly would not be in a case to be eligible in a year, because we do think these new drugs will also only be for mild Alzheimer's disease. So those folks have a decision. Do we go forth knowing the risks? Because these risks are going to be with all the medicine. The reason that these vessels leak is there's amyloid in the vessels too. So when we pull amyloid out of the brain, we pull it out of the vessels and then they leak. So whether they leak fluid or leak blood, that's going to be for all the drugs. We certainly hope it's less than 35%, but we don't know. And so it's just all a matter. I have some people who are like, yes, let's go ahead. I want to do something. I'm not going to sit around. And I have some folks who say, you know what, that risk is too high for me. And even if I miss out, I miss out. And then we always have right now the semaphyllin, but again, that's a placebo plus drug. So you don't know if you'll be getting drugs. So that's kind of what we talk about. And there's no right decision. There's no right decision. It's a difficult decision, but there's no right decision. That's really it, all I have. I mean, do you want me to open it for questions? Yes, ma'am. Okay, the question is there a way to know if it's Alzheimer's? So we are probably 90-something% right just by doing like neuropsychological testing, MRI. We can probably get it right most of the time. Up until this week, Medicare was allowing us to get amyloid PET scans as part of a study. So the PET scan is just a CAT scan with a nuclear material that tags amyloid. And that helps with the confirmation or non-confirmation of that. Now that's on pause right now. They're looking for specific groups, but that will probably start back at the end of the year. Normally that's a $5,000 test. So that's probably the most confirmation. The other thing you can always do is cerebral spinal fluid. So do a spinal tap. It's also less expensive, a little bit problematic on the spinal tap part, but it's usually done at the hospital outpatient. So there's somebody who knows what they're doing with little scopes and mirrors and things to do that. But we can also check the amyloid levels in the cerebral spinal fluid. Mm-hmm. Yes, ma'am. Yeah, so the question is what kind of doctor? I would say that memory medicine would be PCP or neurology. I don't know if PCPs would be as comfortable with something like the aducanumabs of the world, just because there's just so much we don't know. But they can. There's nothing that prohibits them from doing that. Yes. It's rare, but it does, the pairing of Alzheimer's and Parkinson's disease. So statistically speaking, Parkinsonism, meaning Parkinson-like, can happen in a lot of dementias. And so that's what we tend to see in Alzheimer's. We can see that in frontotemporal dementias, but there are folks, small number, who have a true Alzheimer's dementia and a true Parkinson's disease. Oh, talk to me. Okay. We are anxious to have all of them back. So it's been a hard year for everybody. Hard 2 years for everybody. It's been really devastating, and so many of our things that we used all the time got taken away too. So we're grateful to have everybody coming back with their programs. So thank you. There are, Johns Hopkins in particular, the geriatric psychiatry group, Ipsit Valia there, he started writing on that. It's in the American Association of Geriatric Psychiatry Journal. He started writing on that like maybe 3 months into the pandemic when everything was expedited. So they are looking at that. Yes. Okay, so how strong is the genetic link? So in Alzheimer's, if your family member is not a young person, the genetics is very low. The genetics that we worry about is if, let's say you had a brother or a mother who in their 50s or really early 60s, then we start worrying about is that something that's in the family or in the genetics but there's only a few genetic things that predetermines that you are absolutely going to get Alzheimer's. If not, like if you have an older family member, 65 or older is what they call late onset, but those is just a checkbox of a risk. So in the same way I have diabetes as a checkbox, or I have heart disease as a checkbox, having a family member is a checkbox, having 5 family members is 5 checkboxes, but very little is. Now on the frontotemporal dementia side, there is a lot more genetics because that's an earlier disease. So those dementias tend, not always, but tend to have more clustering. But it's really the clustering that tells us that. But thankfully, very few, maybe 5% of Alzheimer's disease is determined by your genetics, or you're determined to get it because of your genetics. Did that help? Okay. Yes, ma'am. Oh, I don't know the identical twin data. I mean, technically, it's still a sibling. It's just, I guess you get a double sibling because you have the same DNA. But no, it's not determinate, though. There's not, I take care of folks who come with their twin, and it's not determinate because your twin has it that you will have it. Absolutely not. Yes. I would guess it would be in the 20s. So there's several South American countries that have clear families with the genetic variants in them, and they've been studying them for a while, and I know they can go down to the 20s. we just don't see that as much here in the United States. But yes. The textbook or board answer is 10 years, but for those of us who do it, I mean, it doesn't follow it. That's just an average. So that's the technical answer from diagnosis, and they don't specify where that diagnosis was. Just diagnosis to death, if you would, is 10. But we have folks over 10, under 10, so, and then a lot of people get diagnosed early and get diagnosed late. I still remember the first day I diagnosed someone younger than me. Because I was still in my 40s at the time, and I remember that day because I had never had a patient younger than me before.
So informative.